Dr. Tony Maddox, and he's consultant cellular pathologist from West Herts Hospital NHS Trust, and he's going to present on a topic that is close to his heart, and that's rapid on-site evaluation. Thank you, Tony.
Well, thank you very much, Alison. So yes, that's me. Let's go to the first slide. First of all, I should say, when I've run through this talk yesterday, it lasts between 40 and 50 minutes, depending on how much I improvise. So I'll try and keep to that time. So these are the objectives. I'm going to try and summarize where we sort of were a couple of years ago. I'll discuss some recent changes, and particularly some recent studies and some newish guidelines that have come out that have discussed rapid on-site evaluation. And at the end, I'll briefly touch on the future and kind of leave a couple of questions hanging that may go up in questions or indeed over the next few weeks and months. So I'll just say up front, I think the key benefits of ROSE, before you get into the detail of adequacy and stuff, are the fact that you can control the specimen. So you're there in whatever suite you're in, endoscopy or an FNA clinic, and you can, based on your assessment of ROSE, you can triage the specimen to cell block, to microbiology, to flow, do these various ancillary tests. And the other key thing, and I'll probably come back to that towards the end, is patient management. So in conjunction with the clinical team, you can make decisions within that environment that will affect what happens to the patient there and then. And that's a key thing which often is not captured in the raw numbers that come out of the studies. But what are the other potential benefits? Well, first of all, there's simply how much stuff do you get and what do you do with it. So there's adequacy, diagnostic yield, and accuracy. Then there are potential benefits in potentially in process. Does it reduce time or increase time? Does it reduce cost or increase cost? And does it change the number of passes or sites, or maybe the number of repeat procedures and patients coming back and that kind of thing? And does it help with ancillary testing? So these are all things that various studies have addressed over the last 10 to 15 years. So if we look at adequacy first, this is really a summary. This is a kind of busy slide. I'm not sure I have I better not do that. If you can see the arrow, but this is a very good meta-analysis, came out about 5 years ago, in which these workers looked at 25 well-controlled two-cohort studies in which they looked at investigations done with and without ROSE. But a number of different areas, so probably very small print for you, but that's lung. This area here is just lots of sites. There's breast, soft tissue, head and neck, only 2 studies there, pancreas, 4 studies, thyroid, quite a lot, mediastinum, only 1, and then lymph node, only 1. And in general, if the dots are further to the right, then that shows a better result of ROSE for adequacy. If we look just at that one study in mediastinum, that's this study from Trisellini in 2011. Actually, it shows, if you just look at the adequate samples, there were fewer adequate samples with ROSE. So this is blind TBNA, not EBUS, but blind TBNA. So with ROSE, adequacy actually goes down, but in any case, not significant. The p-value is greater than 0.05, I should say. And that was a really reasonably well-controlled study. So actually no good evidence that improves adequacy in the mediastinum. But this is from Schmidt's study again, that meta-analysis I showed you a couple of slides ago. But it does show that for pancreas, thyroid, and head and neck, if you look at the column with value, the higher that number, the better. And the ROSE impact was high in all of those areas. So they did find reasonable evidence that ROSE improved adequacy in those sites, pancreas, thyroid, and then non-thyroid head and neck. So, as a brief summary, in the mediastinum, there's no really convincing evidence of improvement in adequacy unless, and they do, a lot of the studies say, unless your adequacy is low to start with. So certainly in the learning curve for a new respiratory physician starting doing EBUS, then most people acknowledge that ROSE is valuable there. But once your adequacy is high enough, probably it doesn't have an effect. Pancreas, some evidence of improvement, but actually there are papers which argue for and against. And head and neck, there was reasonably good evidence of benefit for ROSE on adequacy, both in thyroid and non-thyroid. What about diagnostic yield? Diagnostic yield is a sort of fairly simple calculation, but actually a little bit difficult in practice. So what that is the proportion of patients in whom a particular investigation yields a definite diagnosis. Obviously, if you diagnose a cancer in an EBUS procedure, that is a definite diagnosis, and you can count 1 for that. But the if, for instance, all you find is an absence of malignancy, so a benign lymph node, that's not really counted as a definite diagnosis, and you tend to have to follow the patient up for 6, 12 or 18 months to make sure that lymph node that you thought was benign doesn't turn into something malignant. So actually, the figures can get a bit fluffy. But this was a study in Japan done in 2013. And again, patients randomized to EBUS TBNA, so this is now EBUS rather than conventional TBNA, with and without Rose. And actually, if you look at that very top line, the overall diagnostic yield was better with Rose, but it wasn't significant. This is the pancreas. This is a very frequently quoted paper from Birmingham, Alabama, which actually did show, if you look at the table on the bottom left, the only subgroup where they analysed that did have an effect was on-site pathology. So that did improve diagnostic yield in the US of the pancreas. Curiously, they saw no effect on adequacy, so they had a different result from the initial meta-analysis. So diagnostic...
Sorry, Tony, can I just come in there? Can I ask people to please mute their microphones, please? It's causing interference with the speaker. Thank you very much.
Thanks. So diagnostic yield, mediastinum, not really any evidence that Rose improves it. Pancreas, some evidence, but actually, again, there are papers arguing for and against. Head and neck, actually, I didn't show you any detailed papers, but there is good evidence for adequacy, and therefore, actually, there's reasonable evidence for diagnostic yield. What about process? What about the actual process of doing Rose? So now, finally, we see something. So this is another American paper, and if you just look at in the red box, this is EBUS. The first column is EBUS without Rose. The second column is EBUS with Rose. This was a matched case-controlled study, 340 patients in each group. And if you just look at without Rose, 36% of patients had one site biopsied, but 64% had more than one site, 2 or more. With Rose, almost the opposite is true. 67, 68% actually only needed one site to be biopsied, and 32% had 2 or more sites. So there's clearly a reduction in the number of sites that you need to target with Rose in that paper. And this was our own data. This is from a little while ago, but we changed from conventional TBNA to EBUS with Rose. So we had conventional TBNA without Rose to EBUS with Rose in 2013. And this is our first 50 Rose patients, or 54 patients. But so the purple is blind TBNA, the green is Rose. So it just shows that when we changed to EBUS with Rose, the number of patients that only needed one site biopsy went up to about 68% from about 45%. So it's a clear shift towards only one site needing to be targeted. What about any reduction in number of passes per site? Well, there's one study that does show that. Again, it's a Japanese study, and it does show that with Rose, fewer passes were made per target than without Rose. But actually, we're kind of moving away from that now, because there's a realization, has been for many years, that making the diagnosis is one thing, but clearly you need to harvest enough material for molecular analysis in over 50% of EBUS cases, for instance, because most of them are non-small cell carcinomas. So actually, reducing the number of passes isn't necessarily something you necessarily want to do. Reducing the number of sites is good, but then you often need to harvest that site to get enough for molecular. So that's something that's less talked about now. What is interesting there is this additional procedures, and it shows that without Rose, more patients needed to have additional procedures. What that means in this paper is more sites targeted at the same sitting. So that just recapitulates what we've already seen. And finally, this is pancreas. So this is, again, a paper from America, but it shows that if you look at the table on the left, so this is patients coming with a pancreatic mass without Rose, and again, this is a matched case-controlled cohort study. Without Rose, 22 patients needed another procedure, and that means coming back for another procedure. But only 11 of the Rose patients needed to come back, and that was significant. And then if you look at the patients that did come back, if you now look at the right-hand table, of the 22 non-Rose patients that had to come back, again, when they didn't have Rose, they only got a definite diagnosis in 6, whereas of the 11 that had Rose that came back, they got a definite diagnosis in 7. So a higher percentage had a definite diagnosis on the second attendance, and that is also statistically significant. So overall process, there is a good evidence for benefit in terms of reducing the number of sites that are targeted. And pancreas, some evidence of benefit in terms of whether people have to come back or not. finally, as a big chunk of stuff, molecular testing. So this was a paper from Italy in 2015, and it did show, if you look at the red box, that with rows, so that's the first column is EBUS with rows, the second column is EBUS without rows. So with rows, nearly 91% produced an adequate result for molecular, whereas 80% did without rows. And actually, although there's clearly a benefit with rows, that again wasn't statistically significant. This is an interesting paper again from the States. So what they did is they looked back at 100 cases of lung adenocarcinoma, and they provided rows much of the time, but clearly on some occasions not perfectly. So group A essentially is the more engaged group, in which the cytology personnel are present at the start of the procedure. There's more than one of them, so that means at least two clearly, and the slides are prepared by the cytology staff. Whereas in group B, they may or may not be present at the start of the procedure. There was only one of them, and the slides were often prepared by the nursing staff or somebody who's not in cytology. So essentially group A, they're kind of there and ready to go. Group B, they may not be quite there and ready to go. And when you look at the success for molecular testing, one case from group A, that's the more engaged group, had insufficient cells for molecular testing, but 20, which is 25% of the less engaged group, had insufficient cells. So there was clearly a benefit in that study, and that was significant at p.03. Clearly a benefit in that study from being present at the time of acquiring the tissue. So, molecular testing, in the previous time there is some evidence for rows being a benefit. And a number of studies have come out since then.
Sorry, Tony, sorry, you've got a lot of feedback there. I don't know if you've just caught your microphone or something there. Just try again.
Sorry, I didn't hear that. Okay, so just the last slide, yeah?
Okay.
I'll just say that again. So
thank you.
In the more engaged group, essentially only 1 out of 22 cases had insufficient cells for molecular testing, whereas in the more engaged, so in the less engaged group, 25%, 20 out of 78 failed molecular testing. So there was a benefit for people being present at the time of acquiring the tissue. So there is some evidence that rows is a benefit in molecular testing, or at least there was at that stage. Now what I'll just do is just briefly go through how we do rapid on-site evaluation in West Herts, and I'll just take you through one case just to show you how that works. So we use 3 pieces of glass per pass, but actually it's only 2 slides really. So we put a drop of material on each of 2 slides and use a third to spread them. And we do stain the spreader with MGG, although there's usually very little on it. One of the first slides we stain for rows, it's air dried and we rapid stain it, and the other one is fixed, and therefore we then stain that later for PAP. We put the solid material that we can pick up, the kind of worms, into formalin for a cell block. We hoover up the rest of the bloody material with saline, and we phosphate buffered saline, and we then cell block that later. If we need some for micro, there's a sterile saline flush, and similarly for flow, we do a saline flush into an EDTA tube. And if we can't attend, which is vanishingly rare for EBUS, but there have been occasions, then it all goes into thin prep. And usually that's when they decide to do one on a day that we're not expecting it to happen. So this is the case. This is a 49-year-old woman, and in August 2016, she had a grade 3 invasive ductal carcinoma, breast cancer, ER negative, PR3, so effectively negative, but HER2 was 3+, treated with primary chemotherapy and Herceptin. But MRI showed she had 3 residual foci of carcinoma, so she then proceeded to a mastectomy the following year in April. The year after that, she developed a cough, and the CT showed a right hilar mass, and she'd ever had an EBUS. This is just to briefly show you a splash of colour, but briefly show you the node station. So if you come down the trachea, there's station 1 at the top. Station 2, right and left, are the upper paratracheal nodes. Station 4, right and left, are the lower paratracheal nodes. Station 7 is at the carina, where the trachea splits into the main bronchi. And then stations 10, 11, and 12, and indeed 13 and 14, you're going into the lungs. So 10 is sort of Hyla, and 11 and 12 and 13 are further than that. If you're wondering where stations 5 and 6 are, they're towards the aorta around the back, 3 is around the back, and 8 and 9 are down the esophagus. By far the commonest nodes to be sampled at EBUS are 4R and 7, partly because they're the easiest to get to. But this lady, this is her CT. If you can see the arrow, I'm not sure you can, but I'll move it anyway. So this is just, you can see that the trachea is just splitting into the left and right main bronchus. And so this mass here, which is on the right, you can see an R there, that's in the 4R position. And you can also see on the left, there's a breast implant, which is the site of a previous mastectomy. So that was the site to target. That's the ultrasound showing the needle, which is the straight line coming out from the top going into that grey area, and a bright echogenic capsule along here, but which is rather irregular in shape. This is the setup we have. So there's the table. We bring this in a toolkit with a Hessian bag attached. So a pair of gloves, the stains, A is essentially a fixative, B and C are the stains, and then D is just a buffer. And there's formalin pots, Petri dishes, which is where all our aspirate goes into, some saline pots, and various pens and that sort of thing. So there's the material going directly into Petri dish. That's the entire aspirate goes into that dish. We then put 2 drops on 2 slides, and then so you can see the 3rd slide on the left that we will be using as the spreader. And you can see on the top right in the Petri dish, there's a worm that will be placed straight into formalin. There's a worm going into formalin. You can just see it wiggling down through the liquid, and there's bloody material left in the Petri dish. And we then sort of suck that up with saline and put that in a universal, which we later spin down. That's a slide being stained. That's our setup. That's actually a computer table, costs about 250 quid. Chairs from IKEA, about 25 quid. But the microscope was a bit more than that. With a double header, because it's useful for training and teaching, and not just for biomedical scientists and pathologists, but the respiratory physicians are quite interested as well. So this is what we end up with. So 2 passes here, and you can see those in the tray with a rapid stain and a PAP, sorry, not a PAP, but a fixed slide, which will be later stained for PAP. On the right, those are the worms in the formalin pot, and on the below that is the bloody material in saline, which will be spun down later. We record what we make with every EBUS procedure, so how many passes, what stations, what slides we make, and where the material's gone. We carry everything in that. There you go. There's the toolkit in the Hessian bag. And this is what that patient ended up with. So this is now the stain slides. And again, 2 passes at the top with a rapid Drobunowski and a PAP. And the 3rd slide with very little on. And then there's the cell block on bottom left, H&E, followed by some immuno. And you can see that clearly what we're interested in is whether it's breast or lung. And if it is breast, what's the ER and PR? Because we've done CK7, TTF1, GATA3. And the P40 as well. So, by the by, this is what an adequate slide looks like. This is actually 40 lymphocytes per high power field, amazingly. So that, although that looks slightly scanty, that is just about enough to be adequate. This is what we saw on pass 1 of that lady. So a disordered group of quite large cells with a lot of microvacuolation, fairly high NC ratio, not bronchial epithelial cells. So I was happy to say that that was a non-small cell carcinoma. I clearly can't really tell whether that's breast or lung, but we know that we don't have to sample any of the sites. All we need to do is continue to sample that site. So we could have stopped there. The trouble is, just at the time I was saying we don't need to make any more slides. Can you just cell block the rest? Slide 2 turned up. So I was a little not quite as quick off the mark as I could have been, but that's pass 2. Much more cellular, but the same cells. And we definitely didn't make any more slides. So passes 3 and 4 just went straight into cell block, but we had the confidence to know that that was diagnostic material. That's just a PAP of the same thing. That's the cell block, a very cellular one. You can see how these are the worms that wiggle in and out of the plane of section, but there is also, and a lot of it is blood, but there is also a lot of cellular material there. And that's the immuno. So GATA3 positive, TTF1 negative, so entirely in keeping with recurrent breast cancer, ER negative, PR do for a sort of almost like a 3 out of 8 score, so similar to the previous one, and indeed HER2 positive again. So entirely the same immunoprofile as her primary cancer. That's the block that we make by sucking up the bloody material with saline. And you can see that the dark areas are actually all tumour fragments. So if some disaster happened to the worms in the first block, we could have used that for immuno, and indeed that would just about work for, if it was a lung cancer, for the molecular testing as well. So what about recent guidelines, recent reviews, anything that's new in the last year or two? So this is not the last year or two, but this was the ACCP guidelines. So that's the American College of Chest Physicians. They issued these guidelines in 2016. And what they said, the number of guidelines that referred to rows, but basically it says if you don't have rows, so this is guideline 5, looking at the top right, if you don't have rows, then you should do a minimum of 3 passes. And they then go on to discuss that. And then if you move over to the left of the slide, they kind of say, in conclusion, the data suggests that rows doesn't affect the diagnostic yield, and we've seen that already, but it might reduce the number of times you puncture the node, as well as the number of other procedures, and that's other sites and other procedures and the transbronchial biopsy. And it does say that it might be useful in judging whether there's enough for molecular. But they conclude by saying, essentially in 6, you can do it or not do it, 50-50. They don't make a judgment either way. You can sample it with or without rows. They do say that you probably need to take more for molecular, and they do quote a study which did use rows, and in this particular study by Yarmouth, they found that just over 93% were adequate for molecular profiling, and they did that with 4 passes in conjunction with rows. A couple of years later, the Pulmonary Pathology Society, another largely North American-based group, issued these guidelines, and they said the purpose of rows, they listed 4, and I've moved on to the end, but they say to establish or evaluate adequacy, to ensure adequate sampling for ancillary studies, in particularly molecular, obviously, in terms of cancer, and to provide a preliminary diagnosis. They also say to improve diagnostic yield, and that's my question mark and brackets, because we've already seen that actually we're not sure whether it does genuinely improve diagnostic yield. This is a useful flowchart which kind of summarizes everything I've said about us. But basically, so here's the trachea and bronchi on the left. There's the needle at the top. You've got the needle going onto a slide or onto some kind of vessel. It produces a rapid stain, which you use for adequacy, diagnostic evaluation, and you can use for molecular testing, and I'll come back to that briefly later. A PAP slide, which is stained later. Ancillary studies, which it might be thin prep or a cell block or both. So you see those at the bottom, and you also can use the liquid in that as well as the cell block or anything else for molecular testing. Clearly, immuno is generally done on cell block, and then obviously you've got microbiology if you see granulomas, or flow for lymphoma. They list the for and against, rows for and against, and they say the advantages are you can assess the adequacy. They also say improve diagnostic yield, but in fact, if you look over the limitations, the bottom thing, it says at the present there is no statistically significant results for rows and increased diagnostic yield. So this summary is a little bit conflicted anyway. They do talk about reduction of additional procedures, and so that I think we've established that, and the papers do establish that you can reduce the number of sites you target. And you obtain additional passes for molecular testing and stuff. Better use of laboratory resources in terms of total number of slides, probably. Of course, that doesn't necessarily apply if you stick everything in formalin up front, but if you're doing cytology, it does. And improve patient care. The issues are that essentially time and resources. And particularly in the US, there is an issue that attendance at rows is not well reimbursed. So that's a particular issue in that healthcare system, and also it's time consuming. But their conclusion was that the evidence supports the inclusion of rows in every EBUS TBNA whenever feasible in patients with suspected lung cancer and in large nodes. This was a study or a meta-analysis from India this year, and essentially they asked, it's a very extensive paper, it's a very good one, but they asked this question, should rows be performed routinely? And they say it should be used during EBUS TBNA wherever available. And they review a lot of papers in order to come to that. So the wording is kind of moving towards should. And this is, I think, it's certainly online, but I don't think it's quite in print yet. So this is going to be in the Archives of Pathology and Laboratory Medicine, which is the house journal of the College of American Pathologists. So this is now guidelines produced this year by the CAP in collaboration with kind of all of the previous plus more. So the American College of Chest Physicians, the Association of Molecular Pathology, American Society of Cytopathology, Thoracic Society, Pulmonary Pathology Society, and all of those. And they come up with sort of 4 recommendations that mention rows. And basically the first one is, when you're performing EBUS TBNA, rows should be used if available. They then talk about how many passes to do, and that's to do the recommendations 4 and 5. 5 is interesting because they're talking about transthoracic needle procedures, and there they mean transthoracic FNAs, but also core needle biopsies that you then dab onto slides to perform adequacy on, and that's a fairly common procedure now in North America. When talking about recommendation 3, which is this business of EBUS TBNA and rows should be used, in their discussion they say there's a trend towards increased diagnostic yield, so between essentially 3 and 8%, although they do acknowledge that that's not quite statistically significant, but they do acknowledge that there is possibly a small benefit. They say in studies without a control arm, which is obviously most of them, in the sense that most studies don't compare rows with non-rows. Most studies just say this is what our experience is with rows, but they tend to show that there is a high sensitivity. That is, they're good at picking up disease in these studies that talk about their experience with rows. They again stress the decrease in the number of targeted sites and also talk about the decreased complication rates, partly because you are decreasing the number of sites you target. And they say there's possibly an increase in success for molecular analysis, but they acknowledge there are relatively few studies. So interestingly, there was a consultation phase, and 238 people wrote in, and 3/4 of those agreed that rows was a good idea. And the written comments were mostly supportive, but those that raised concerns had the usual things: personnel, time, money. And return this business to this business of wasted material. And this is feeling, or there was a feeling, that material spread on slides to do rows is wasted from the point of view of doing anything else with it. But that's not the case, because guidelines came out just last year from the Association of Molecular Pathologists, along with the CAP and others, saying that material on slides is perfectly good material, in fact better than formalin-fixed material, to be scraped off and tested for molecular. So if you have a cellular direct smear, that's a very good substrate for molecular analysis. And we've recently done a study here and showed that actually the amount of material used for rows is tiny. And hopefully that paper, we're just about to submit it, but I mean, it's much less than 5% of the total material. So I think that the idea of wasted material is not the case. They also say elsewhere, and this is now talking about transthoracic needle procedures. So these are all FNAs, in fact, taken through the chest wall into lung masses. And if you look at the diagnostic yield column, CSC is conventional smear cytology. All of them do show a benefit with rows. So the diagnostic yield actually does go up in these cases from 76% to 90.6%, and all of them show a diagnostic yield in the 90s. So actually, this is not EBUS, but it's transthoracic FNA. There is an improvement with the diagnostic yield with rows, and also the complication rate was lower. The current RCPath guidelines, the tissue pathways for diagnostic cytopathology, which came out last year, essentially say something recommended if resources permit, because it gives you control of the specimen, sample triage. There's an immediate feedback for the clinician, and it does improve adequacy in the head and neck and the reduction in sites targeted in the thorax. So in the final bit of the talk, I'll talk about who should do rows, or who can do rows, and see what studies show us about who does do rows around the country. So at West Herts, and in many places, it's a cytopathologist and a biomedical scientist, but around the world and also elsewhere in the UK, there are pure BMS teams. And are there any papers describing anybody else doing it? So this is, I think, Australian, if I remember correctly. What they do is they compared respiratory registrars, so these are respiratory physicians in training, not people completely outside pathology, and BMSs, medical scientists, and then used the gold standard of cytopathologists. So they said that the cytotechnologist, the biomedical scientist, had a degree and a certificate, and they stated they had included 50 supervised rows cases. So you'd have to say that the BMSs had probably more experience, because the registrars essentially got 4 one-hour sessions. And that must add up to less than the combined experience of the cytotechnologists. But nonetheless, how did they do? Possibly not surprisingly, if you look at the concordance, the BMSs were concordant 90% of the time, if you look at the percentage column, with the pathologist diagnosis, but the 2 respiratory registrars were in the 70s. So possibly they were at a disadvantage, but the BMSs clearly performed better there. This is comparing a cytopathologist and a pulmonologist, so a respiratory physician, and this is an American paper. And actually, if you just look, so the respiratory physician or pulmonology is at the top, columns, if you like, and the pathologist is at the rows. And actually, there's good correlation. There are only 3 cases where the respiratory physician thought the cases were, this is purely adequacy, by the way, thought they were adequate, but the pathologist thought they were inadequate. And this is the same paper, and it just shows that, so the highest numbers are the concurrence over benign, nearly 70, and malignant, 61. And of note, it's worth noting that there were no cases that the respiratory physician in this study thought were malignant, that the pathologist thought were benign, and also no cases that the respiratory physician thought were benign, that the pathologist thought were malignant. So they didn't have any true false positives or false negatives, which is pretty good. This is a similar study from Italy, where again they got a respiratory physician, and they went into the training in a fair amount of detail. There were 3 phases. There was a training phase, which isn't shown in this table, where they looked at archival material and read papers and that kind of thing. There was a test phase where they looked at 50 slides, and in that phase, the respiratory physician agreed with the pathologist 84% of the time. And then there was a real-time phase with real EBUS cases where the pulmonologist was sat in a separate room and looked at the slides after the pathologist had looked at them, but scored them independently and blindly. 380 slides from 303 lymph nodes in 200 patients. And you can see that the agreement does sort of, it's all around about 90%. So, you know, you'd think that's not bad. But the interesting thing is actually, although the agreement isn't bad, there were significant numbers where the pulmonologist thought in 11 cases that the cases were malignant, and the pathologist thought 1 was inadequate and 10 were reactive. And then there are also some false negatives where the pulmonologist thought essentially 14 were either inadequate or reactive, and the pathologist thought were malignant. And just musing about that, in rows, obviously false negatives and false positives, neither of them are great, but in a false negative, if there's a high suspicion of malignancy in a patient and you don't see, there's a tiny focus of malignancy on the slide and you miss it, or it's hidden amongst lymphoid cells, in general, most of the time, the clinician is probably going to go on and either take more samples from that site or possibly even move to another site. So there's less of a risk of something going wrong for the patient. A false positive is more of an issue, because if you say, okay, that's malignant, in our practice, you would stop making slides, you wouldn't target any other sites, and you'd just carry on harvesting that site. And if it then turned out on cell block that there was actually no malignancy, the patient then does have to come back and have a repeat procedure. So neither are great, but a false positive at rows is probably a little bit for the patient, a little bit worse, as well as even if they may be given some information which turns out to be not true as well, which is another issue. Anyway, this is the position statement issued in 2016 for the role of biomedical scientists, and essentially what this says, and this is a joint position statement from the RCPath, the BAC, and the IBMS, and it says a comment on adequacy, and they say that that's equivalent to rows, can be offered by biomedical scientists, and if they have suitable experience, they may also be able to offer a preliminary opinion mainly for triage as well as for rows. So it's already kind of allowed to do that. So who's doing it? This is a study, Tracy Stevenson's study, which was published a couple of years ago, and this is an entirely BMS-led service, showing that they, in the red box, this looks at their molecular analysis, they have 96.6% success, which is very good. This is Leonie Glinsky's paper, also from the Southwest. And again, if you look at their, molecular success rate, and that's the column that says number of cases, sufficient sampling. The last column, the sufficient sampling for molecular or tumor profiling, 100% immediate and 93%. So, you know, very good results there. Denmark, paper published in Cytopathology, and essentially if you again look at the this is with BMSs going to clinics and performing adequacy and initial diagnosis in a binary split between malignant and benign. If you look at the adequacy, which is the top 4 numbers in the top left, they're only discordant in 13 cases where the BMSs thought it was inadequate and the pathologist thought it was adequate. And if you look at diagnosis at the bottom right, again, there are only 2 discordant cases, although they were both false positives. So in the USA, there was a study last year where they looked at who essentially American Society of Cytopathologists around a survey say who's doing rows and how are you doing it. Interestingly, 20% nearly of the ASC membership replied. The ASC membership is 2,778, so in a population of 300 million, that means that about one in every 100,000 are members of the ASC. And I think the BAC is probably about 1 in every 150,000, so we've probably got a little bit of catching up to do. But the main people that replied were the cytopathologists and the cytotechnologists, the BMSs. The main hospitals that were represented were the big centres, academic centres 56% and private hospitals 36%. Annual volume, so actually, the majority were between 1,000 and 10,000, but there are significant sites doing, 10 to 15,000 and more, so some very big areas. This is the thing, how many offered rows? In the academic centres, 97% of respondents offered rows and 96% nearly in the community or private hospitals. So a big percentage. Who offered it by telecytology, which we'll return to right at the end? In the academic centres, nearly 30%, community hospitals, 12%. So already it's gaining a foothold. And that's, the bottom table is split by workload. So in other words, those labs that did between 10 and 14 or 10 and 15,000, actually 40% of those were offering telecytology. So that's clearly a growth area. Who does it? About a third, if you look at the top two circles, were both pathologists and BMSs. Next two circles, BMSs alone, about a quarter. Cytopathologists alone, pretty uncommon in academic centres, but actually about a quarter in community and private practice. And this is a thing called a violin plot, apparently. But essentially, if you look at EBUS TBNA, what they would say is how many of your EBUS TBNA procedures is rows offered for. So if it's 100%, you end up essentially in that green blob at the top. If it's 80%, you end up on that line. So the mean there is about 60%, sorry. So overall, across the people that responded, 60% of EBUSs in their practice would have had rows offered. The interesting thing is the final violin plot, CT-guided core biopsy plus or minus touch prep. So a significant number of people are offering adequacy based on the touch prep of a CT-guided transthoracic core biopsy. Let's ignore that. So this is a recent, well, 2018, but a fairly recent systematic review and meta-analysis of diagnostic accuracy studies in FNA by non-cytopathologists. So that this is both biomedical scientists and people who are not pathologists at all. Sorry, not from the pathology discipline at all. This is probably easier to understand. So the boxes in red are the cytotechnologists, the BMS studies. And the ones in white, of which there are only 4, I think the top 2 are pulmonologists and the bottom 2 are endosonographers, in fact. And it shows that in general, sensitivity is pretty good. That is, if there's something there to see, malignancy or whatever, then most studies show that non-pathologists are pretty good at picking it up, apart from those 2 you can see as outliers. Specificity, that is how good are you at saying that disease is not there, are more variable. There are some excellent studies, and in particular SHACT, which is in the box up from the bottom, that's the Danish study we talked about earlier. They have excellent results on both sensitivity and specificity. But in general, and I have to say these are multiple sites, so this is lung, mediastinum, and pancreas, liver, thyroid. This is rows at a number of different sites by a number of different modalities. In general, the specificity of BMSs was better than pulmonologists and I think the other non-pathologists as well, the endosonographers, so 86% versus 75%. So again, the BMSs came out on top. They concluded that rows performed by a non-pathologist was probably better than not having rows at all. And the studies involving, the interesting thing was studies involving people not from the pathology disciplines, so the pulmonologists and the endosonographers always went into detail, as you might expect, on training. So what training did they have? How many slides did they look at? How long did it take? What tests did they do before this? So whereas most BMS and cytotechnology papers do tend to say they have this number of years of experience, they may have got this certificate, but they don't go into any specific training any more than that. And in this paper, they question that, and they quote a study which showed that BMS accuracy for rows improved from 75 to 90% after specific training for rows, despite their long experience in other aspects of cytology. So that's an area that needs looking at. And they observed that in this paper, as I said before, that some rows benefits are simply not captured in adequacy studies. And what they quote is an example, for instance, whereby one might say in the endoscopy suite, well, this EBUS FNA is inadequate of that site, and they may decide, well, let's do a transbronchial biopsy, for example, or something, which is then successful. So all of that would then look in the raw data afterwards is that Rose was inadequate and had a poor diagnostic yield, but the transbronchial biopsy was successful. But the truth is, the fact that they were present in the suite at the time and were able to contribute to the direction of investigation at that time is one of the advantages. It's just difficult to capture that data. And they also note there's a wide variation in studies. In the end, they say, well, we can't really generalize whether Rose is a good or a bad thing, but there are some interesting points that came out of it. So 2 years ago, when I first started talking about this stuff, it was pretty clear there was a role for Rose inadequacy in the head and neck, and particularly in the thyroid. In the mediastinum, there was limited role for adequacy in diagnostic yield, but a clear advantage in terms of reduction in sites targeted. And in all sites, there was an advantage in terms of sample management and triage. So what about now? Interestingly, the guidelines and the various meta-analyses have kind of moved from saying, well, you can offer it if you've got it, to you should offer it if you can. So the word should now appears rather than could or might. It's clear that it can be done by non-pathologists, but that the whole gamut of non-pathologists, including biomedical scientists and people who are not from pathology at all. But training and structure are crucial. And on that point, BMS training is rarely mentioned, and I think that's an area we can clearly improve on. So in addition to any experience that biomedical scientists may have, a particular Rose training is clearly something we should be doing. Final thing, and there's really only 2 or 3 more slides. This is a paper from 2 years ago showing implementation of telecytology. We've already alluded to that in the American stuff. And this is from Pittsburgh, and detail their experience of how to deploy telecytology. They have multiple sites they need to service for Rose, and how are they going to do that? And that's a very interesting sort of nuts and bolts type paper. There's a biomedical scientist scanning the slide, and that is transmitted in real-time video to a consultant and a fellow who are then assessing it in their offices. Happily, the current issue of Cytopathology is a digital imaging special, which includes a number of articles, both on digital imaging in general, whole slide imaging, but also telecytology by some of the same group and others. So I recommend that. It's only literally just arrived on my desk, so I haven't managed to get through it yet, but that's clearly a growth area that we're going to be interested in as well. And so that's the issue we should all be reading. And that's it. Thank you very much.
Okay,